Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you. Welcome back to Between Two White Coats, and today we are super thrilled to have our good friend and person who has helped us take credit for saving lots of lives, Dr. Marcus Sims. Marcus, gosh, how long have we been sharing patients with each other?
Probably since 2011.
2011.
Yep.
So yeah, lots of years. And Amber and I always say we would not send our patients to someone who we would not see or send our own family members to. And you are the proof and evidence of that because you have taken great care of my dad. Right. He always has fabulous Dr. Sims stories for me. Mm-hmm. And he's stubborn, man, and you get him to do what he's supposed to. So I appreciate you more than you know. You've taken care of my husband. You have taken care of so many important people in my life. So we want to welcome Marcus Sims, a cardiologist who is going to be helping us navigate one of the most important things we can talk about: heart disease, congestive heart failure, ways to keep your heart healthy. So Marcus, tell us a little bit about yourself, and then we'll jump into talking about the heart.
All right. Well, thank you for having me today. And I'm glad your dad's doing good.
He's doing great. Won't slow down.
And he likes to stay in his garden.
Yes, he does.
So we talk about that all the time. But yeah, so I'm, I guess, an interventional cardiologist. I'm the chief of medicine, head of cardiology at Piedmont East Side in Snellville. In 2011, 2012, me and Dr. Underman came out here, or he was already out here since he's an old stag.
Love Mark Unterman as well. What a great guy.
Right. And we thought, it was basically a good idea to help bring cardiology to this area and awareness. So I originally, I'm a military brat, was born in Germany, as we talked about earlier, on a military base, and have a son who plays over in Germany now. But when my dad retired from the Air Force, moved to Decatur, Georgia. So I claimed Decatur, Georgia, and Stone Mountain as home because that's where I went to high school. And then basically went to Morehouse School of Medicine, University of Florida for residency, and then went to George Washington in D.C. For cardiology and interventional cardiology, where I was the first black.
I did not know that about you.
Yeah, chief of cardiology there, even though I'm mixed, as we talked about earlier.
Yes.
But yeah, and then I decided to come back down south because there's a lot of, cardiac issues.
Well, it's home for you. How do you deal with being? I'm assuming you're a Gator fan in Georgia territory down here. How's that work out for you?
So
like, has nothing to do with the heart, but I can see that would be like
exactly. So a lot of the people at Piedmont have the big Georgia G on their
scrubs.
Well, on their scrubs and on their 3/4 length zip ups.
Yeah.
And I'm like, we're all in SEC, but I jokingly, people support teams and they never went to school there.
Yeah.
I want to support all the teams that helped me get where I'm at.
Yes,
so when I was at the University of Florida, I made $35,000 a year as a resident, and they helped me to become a cardiologist. So
yeah, that's right.
Since I did my residency at Florida, I became a Decatur Gator. and so that's kind of where that kind of leads into all this with the SEC.
Yeah, I love it. We're going to jump in today to talking about a very important topic, heart disease. And in heart disease, we want to focus in this episode on coronary artery disease and heart attacks.
Sure.
So number one cause of death, super important. I would like to start on prevention. Okay. Amber and I and the practice that we have here in primary care are all about if we can keep you from getting sick, that is so much better and so much easier than trying to get you back from getting sick. I have consistently had frustration in practicing primary care with preventing heart disease because United States Preventive Task Force does not give us a lot of guidelines on what should we do for screening?
Sure.
There's, heart disease will kill more people than the cancers. And we have prevention for colonoscopies to prevent colon cancers, mammograms to prevent breast. But it's hard to get a cardiac screening test on people. And so let's start with, if someone would like to simply prevent the heart attacks and cardiovascular disease, who would be appropriate for those types of things, and what recommendations would you use for that?
Yeah. So, I would say if you want to prevent having cardiac disease, you probably need to become a vegetarian, which most of us in the South don't do. And so the good thing, like you said, the U.S. Preventive Task Force doesn't really have any, recommendations on stuff. So most of the time in cardiology, we practice, our guidelines from the American College of Cardiology and American Heart Association. So usually people over the age of 20 should have an EKG done. They should have their cholesterol checked at that time, because if you have a family history like me, then you want to know if your kids, later on in life could end up having heart disease like their grandfather or their grandmother. At 40, you should get a calcium score CT, which I thought, it was 50, but when I went back to look at the guidelines, it's at age 40. So.
And is that across the board for people, whether they've been treated for hyperlipidemia, high cholesterol?
Yes.
Okay.
Yeah. And so the other issue with that is, right, in the last 10 years, insurance companies didn't pay for you to get your calcium score CT.
Yeah.
Right. And it's only, I say only, but $90 to $150 out of pocket for you. I mean, you could go spend that on your kids at a AAU basketball
We
game.
were just talking about how we get to pay at the door for all the things we've already paid for in AAU basketball. Yes.
Right. So
it really is, if you're prioritizing your health, think about spending $100 on a cardiac calcium score.
Right.
Is insurance paying for it now?
Yeah, a lot of them are, because, they were losing out, right? Some insurance companies were paying for it, some weren't. And so that kind of started when folks would get their cholesterol checked and they don't want to take a statin, right? And then you needed some more evidence to prove that they needed to be on a statin. And so calcium score came in, and then you would submit it to the insurance company, and they tell you, they either they're not going to approve it, or you have to go see a cardiologist to get it, so now you're paying another copay on top of everything else just to get to the next AAU basketball game.
Yeah. Right. The cardiac calcium score, can you explain exactly what that is?
Sure. So if the score is less than 400, basically you're going to be low risk. If it's some data shows that if it's over 300, then you're at an elevated risk. But most of the time in my patients, if it's less than 400, you can say, hey, you're fine. Yeah, it's 150, you're at elevated risk. This is what your LDL is. We should be on the statin. But if you're less than 400, you should be fine. My calcium score was 0.6, so I was upset about that, because, why can't I have a zero?
Right.
Having 100 on a test grade.
I'm an achiever. I can't be 0.6.
Right, but, if you're going to do stuff, like you said, you want people to feel comfortable with you and treat people like family. So if I went and got my calcium score and I'm 53, then your family members who are over 40 should go get it, or give them a voucher, or not a credit card, but buy them a gift card, from Kroger's or wherever, and then say, hey, use this to go get your calcium score, so we can kind of know what's going on with you. But so, like I said, if you're less than 400, check your cholesterol, then we can make some recommendations. If it's over 400, then I'm more concerned that you may have heart disease. Some cardiologists believe that if your score is higher than 400, just go straight to heart cath.
Okay.
Which, because I'm an interventional cardiologist and because of the guidelines, I've seen a lot of people, you have an elevated calcium score. I tell them it's like having gray hair, right? You can hide it. If you're a woman, us guys who really don't care about our grays most of the time.
There's a lot of energy that goes into covering this gray. Yeah.
Right. But so, for me, and just the volume of people that I've seen and that I've cathed, the calcium just is kind of an elevated risk of possibly having significant blockage in your heart. And most of the times, what I do is I get a stress test, or I might get a cardiac CTA, depending on your risk profile, which is just more specific, and it can show how significant the blockages are above and beyond the calcium score. And they can do another measurement called FFR, which they measure the flow across the vessel. And if it's below a certain number, then you have significant disease. Then we go to cath. But all that, is really progressive Western medicine. If we were in Germany, or if we were in South Africa, or if we were in South America, you wouldn't have all this extra CT, MRI, echo, and whatnot. So going back, how do we prevent all this? You want people to exercise at least, 30 minutes 3 to 5 times a week. Ideally, they say 150 minutes a week, or 75 minutes of vigorous exercise. You want to follow a Mediterranean diet or lifestyle, which my older son does. When we were up at Ohio State this past weekend, every night it's like, can we go to Mediterranean? Can we go to Mediterranean?
Oh.
And so I think the younger generation, because of social media, they're more educated about nutrition and diet and exercising, where we're kind of stuck in how people live in the South versus in the North or out West, and how that's predicated.
So what I'm hearing you say is, first, you don't have to have a single thing done to yourself to eat right and exercise. You don't have to have health insurance. You don't have to pay $99 for a cardiac calcium score.
Right.
But you can keep the meats out of your diet as much as you possibly can. Think Mediterranean diet, which is a very heart smart diet. And then watch your cholesterol levels, because in general, what I say to patients is cholesterol is like dropping grease down the drain. And the first drop or two of grease in the drain is likely not going to create a clog. But you keep dropping grease down the drain over time. Next thing you know, the pipes are clogged and nothing can get through.
Right.
And so first we want to see how much grease is there, and that's going to be looking at your lipid levels.
Right.
As far as looking at cholesterol levels, then at 20, we should start looking at our cholesterol levels. What is the recommendation of frequency to repeat those cholesterol levels?
So, I do it at least once a year.
So do we. I think we really try to push people to get their annual wellness. In America, common cause of death is heart disease. So even my healthy runners and people like that, I'm like, probably won't hurt us to look at a cholesterol, because a lot of this is genetic. So let's just stay on top of it.
Right. So you get half of your bad genes from mom, half your bad genes from your dad, and then you have bad cholesterol. But, if you're high risk people, if you're diabetic, if you've had coronary artery disease or a heart attack or a stroke, or you have peripheral vascular disease or blockages in your legs, those are our high risk people. So, they definitely need to have their cholesterol checked and need to be on the statin therapy and that high intensity, because their risk of having another event is, tenfold of what somebody who, has normal cholesterol is. So I jokingly say, if we just drop statins in the Chattahoochee River, everybody would be all right, or Lake Lanier. Right. But ideally, we can't do that. So
and
in Georgia,
if you see there are different specialists who would drop different medicines into the water supply. If you're a psychiatrist, you try and get a little SSRIs into the water supply. Sure. If you're a cardiologist, trying to get a little statins to spread around a little bit more.
And make our lives easier.
Sure would. We get to take a vacation every once in a while.
We get, I will get a ton of pushback.
Somebody put on Facebook that you shouldn't take a statin at some point.
Yes.
It's all we
I
hear.
get a ton of pushback about statins. And so I always will tell patients, I'm like, you won't take a statin until you're face to face with a cardiologist, because you've had a heart attack. Right. And so, which you may not get as much pushback. Do you get as much pushback about statins as we do as from primary care?
Probably not, because now they're at the cardiologist. But also I kind of integrate life stories. Like my program director, George Washington, he always would tell, older Jewish guy would always tell all these stories to all the patients. I'm like, man, you're killing me with these stories. You're spending 5 or 10 minutes more with these people, but I think telling the story where people can relate to it helps to kind of...
We like to speak in research. We like to talk about the double-blinded study.
Right.
And patients want to hear, well, what's it going to look like for me?
Right.
And when they can relate to, this went south for someone, and you can keep that same story from happening to you, then that's where you get their attention.
Right. Yeah. So in my world, like I was telling you guys, my dad died from heart failure and cardiac arrest. I ride around, I have VTAC on my car, and most of the medical people know what VTAC means, but I said, when I get a nice car, I'm going to put that to kind of remember my dad on a daily basis. But so at 30 in residency, where the drug rep companies sponsor, your noon lecture, right? So what are you having every day? You either having Jimmy John's or you're having pizza, and you're working 60 to 80 hours, and for depending on what year you went through your training, you were doing 120 hours, which the younger guys and girls now.
We thought that it should be better, and we're mad that they don't have to do it.
Right. So I checked my cholesterol in my 30s, and my LDL was 169, and so I'm like, I'm not taking a statin. I'm going to diet and exercise and try to get in shape how I was when I played soccer in college. And lo and behold, a month later, I checked my cholesterol and it went down. The LDL went down 5 points, which that's kind of, what's going to happen. So people think, oh, if I change my diet and I exercise, I can improve my numbers, but they're not going to improve the numbers to the 50 to 60% that statins do. So my next thing is just like regular patients, right? Well, I really don't want to take a statin. What else can I take? So I took niacin, and I took niacin for 2 weeks, and then I was going in to do morning report at the University of Florida, and I get in my car right after I took the niacin, and I felt like facial flushing, and my ears were burning, and I'm like, am I having facial flushing, which is the most common side effect from niacin? Like, damn, So I called my chief resident because I was giving morning report that morning. I said, hey, I just started taking niacin 2 weeks ago. I think I'm having facial flushing. I'm going to go back to the house and take an aspirin. And as soon as I took the aspirin, 5 minutes later, the facial flushing went away. But it also gives you dry skin. So, there's going to be side effects from all medications that you take. You just got to know your risks of them. So I knew that didn't work. The diet and exercise didn't work. And so if I take Lipitor, the worst thing that can happen, my liver enzymes go up, right? Or I have myalgias. And so I got on it. The liver enzymes didn't go up. I didn't have the myalgias or arthralgia, and or the muscle pains and bone pains. And so I was a lucky person that could reduce that number. So my LDL went from 169, down to 69.
Yeah.
And so
you just have quietly stayed on a statin since you were in your 30s.
Correct. Right.
Yeah.
And so for patients, usually a month after therapy, I'll check their cholesterol again. And some people wait to 6 months, but if you wait 6 months, people will slide back in that bad habit and they won't take the medication, and then you're checking their numbers again and they hadn't made any improvements. So
we're talking a little bit about statins, and you mentioned LDL level in the 160s. I think that when it comes to cholesterol levels, it can be difficult for people because there are different cutoffs for different scenarios. First, let's talk about a lipid panel. A lipid panel has your total cholesterol, your good cholesterol, which is HDL, and then a couple bad cholesterols, triglycerides, and LDL.
Right.
That's typically what you'll see when you get just a basic cholesterol. Right. And that's one of the tests that we like you to be fasting for when possible. It's going to give us some more accurate. What are in different times when I'm at cardiology seminars, I'll hear, hey, HDL is super cardioprotective. And we don't really know if we think HDL does a whole lot or doesn't do a whole lot. LDL should be 130, LDL should be 100, LDL should be 70. So give us some guidance on what these numbers should be. Yeah,
so, most of the data has kind of panned out where, as a cardiologist, we really don't look at the total cholesterol or folks' HDL or the triglycerides. Even last time I was studying for the boards, you don't really have to get a fasting because you're really looking at the patient's LDL and their risk factors. And so we look at their, ACCVD or atherosclerotic cardiovascular disease score or profile. And if that number or the percentage is greater than 7.5%, then, they probably need to be on a moderate intensity statin. If it's greater than 10, then we're talking basically high intensity statin.
So looking at the risk score, going into those calculators, answering all the questions and seeing what their risk is, despite whether one of those questions in there is going to be their LDL. Right?
Sure.
And so that then is going to decide whether you should really be on a statin or not, because you're looking at the total
risk.
Right.
So you're going to be looking at sex, age, blood pressure, and then the LDL cholesterol, and then other risk factors like, are you a diabetic, do you smoke cigarettes, will be in that profile. And so what that'll tell you is if your risk score is over 20%, then you have a 1 in 5 chance of having an event, whether it's, chest pain and angina, coronary artery disease, a small heart attack, which is a non-STEMI, or a big heart attack. So that's 1 in 5. If your score is between 7.5 and 10, then 1 in 20 chance of having an event. So, do you want to have basically you want to lower that risk as much as possible by keeping your blood pressure under control, exercising, checking your cholesterol to make sure it's where it needs to be. So high risk folks are people who've had strokes, had heart attacks, diabetics, and a lot of times women that are diabetics get skipped over because you don't have the typical symptoms that men have.
Yeah.
And so, or you're taking care of the family all the time, and you don't worry about yourself. You're worrying about the kids, you're worrying about your husband, what your boss wants to do at work, or if you're the boss, then you're worried about everybody else except for yourself. So I think that's really important that gets skipped over is, women's cardiac health care.
I actually did my graduate study, which granted at this point it's been forever ago now, but I did it on African-American females and the risk of heart disease because they get skipped over, especially African-American females.
Right.
But their risk and the biggest risk factor is they were worried about everybody else. Like all the studies, essentially all the data that we collected was that they're worried about taking care of their family, taking care of or working or whatever. And it's so interesting that even now, that's been like over 20 years ago, that you're saying the same thing.
Oh, yeah. And so over 20, so I left DC in 2008, but there was attending, she was at Washington Hospital Center, and she said women don't have the same symptoms that men have. But if you ask them, when's the last time you've been shopping, right, at the mall, which most people don't. So
don't even have malls now.
Right. So now, when's the last time you've been shopping on Amazon? But that's probably a little bit easier, right? Yeah. Or when's the last time you've cleaned your house, or, went out with the girls? And a lot of times when you see a woman change her lifestyle, then something's going on with her health-wise.
Oh, that's interesting too. Yeah. Couple other quick questions. So our LDL goal for a person, do you take in risk factors in, and LDL goal should be what?
Ideally, I tell people, if you're normal and healthy, less than 130. If you have some risk factors, then less than 100. If you've had an event, either stroke, heart attack, peripheral vascular disease, or diabetic, or bypass surgery, then we want that less than 55. And I say my little happy fingers or my magic fingers, and so I strive to get them there. And a lot of times you won't get that just with statin alone, so I throw on Zetia. And then I think insurance companies have gotten a lot better with letting you guys order, PCSK9 inhibitors. But if that's the case, then I'll drop the Zetia, keep them on the statin. Once we get them less than 55, then I can consider, lowering the dose of the statin or coming off the statin altogether, because, you get 60% or more reduction on the PCSK9 inhibitors, whereas most statins, 50 to 60.
And is there a cholesterol that's too low?
Not really, but if you see that somebody has a low cholesterol and they're over 50, then you want to make sure that they've had all of their screenings for cancer, because some studies have shown if you have a super low LDL, you may have a colon cancer, smoldering, or prostate cancer. Oh, that's
so interesting. I did not know that. Mm-hmm. And so get the LDL down. Look at cardiac calcium scores as a potential screening.
Sure.
Cardiac calcium scores then may get you a referral to cardiology to make sure we're staying on top of stuff if it's elevated. I think most of the time when someone is high risk, I end up sending them to cardiology, not because we can't just go, well, let's get your cholesterol down. But I think when they sit in front of you too, it's a bit of a wake up call to say, sure, let's globally look at how we prevent a heart attack, because you're a person who's looking at significant risk.
Right.
And then speak a little bit more about the cardiac. We see that you may be at risk, or maybe you're having chest pain, or we sure, say that there may be something that's related or making us worried about heart attack. When do you choose stress test versus other testing, and who should get those?
Yeah. So, if you have somebody with atypical chest pain, not really a lot of risk factors, meaning more than 2 risk factors, then I'd probably just do an exercise treadmill test. You know, it's cheaper, easier. You may get into trouble with some folks who, you know, that are morbidly obese and they can't walk on the treadmill, so you can actually do a dobutamine stress echo, which you just give them an infusion, which will get their heart rate up, because that's all we're trying to do is get the heart rate up during the exercise treadmill test and making sure we don't see EKG changes. If somebody can't walk, if you get a DSC or dobutamine stress echo, you're also getting imaging, so you can see the walls, you know, at 0 minutes, at 5 minutes, at 10 minutes, at 15. And if you see one of the walls not contracting at 15 minutes, but it was contracting at rest, then you know that they have a blockage in that region of the heart. And then we have the nuclear stress test, which kind of, the sensitivity on that is 90 to 95%. So when you're looking at these tests, you know, exercise treadmill test, the sensitivity is probably 40 to 60%, right? And then dobutamine stress echo somewhere in the 70s and 80s. Nuclear stress test is more sensitive than that. And then, you know, back in the day before we went through training, you know, you could get away with, oh, somebody comes in with chest pain and they have a couple of risk factors, let's take them straight to cath. Well, insurance companies don't like paying for cardiac cath until you've, you know, maximized the medical therapy, you've done some kind of stress imaging test, and then they'll approve, you know, for you to have a heart catheterization. My nurse practitioner, while I was out on vacation, you know, she called me. She's like, I'm so stressed out. I'm trying to help this patient. And I know the family really well because I took care of the mom who had coronary artery disease, and I put a stent in her 15 plus years ago, and she was a diabetic, and then, you know, she fell off the wagon a little bit, and so then she had a blockage in another one of her vessels, which was right at the left main in the LAD, and so she was in Jamaica and wasn't feeling good, and she went to the hospital there, and they said her heart rate was in the 30s, and in Jamaica, you know, you have to mortgage everything just to get admitted into the hospital, and this was 6 o'clock in the morning. Most of my patients have my phone number, even though, you know, that doesn't give you your total freedom away from patients. But I told her, you know, go to the airport, get on the plane and get here. So they got here about 11, got to the ER. I happened to be on call that day, and took her to the cath lab, and basically she had 3 vessel disease, and I had to put a temporary pacemaker in her. But now fast forward, her daughter, who's just turned 60, isn't feeling well, having chest pain, diabetic, and the insurance company, you know, wouldn't approve her heart cath even though she had an abnormal. Well, her stress test was equivocal, so I got a cardiac CTA with the fractional flow reserve, which was abnormal, and they still didn't want to approve her left heart catheterization. And so my nurse practitioner was just frustrated with the whole healthcare system. She's like,
because
she has
it's not going to be
significant family history. Like it's going to end up worse for this patient when you could have probably put a stent in, maybe.
Exactly. So stay tuned. That'll happen, you know, this week, tomorrow. So.
Wow. So we've talked about a little bit on how to prevent getting to a scenario of chest pain. And I'm going to ask everyone to join us on our next episode where we talk to Dr. Sims a little bit more about chest pain and when is it possibly a heart attack versus something else, and what should you do with chest pain. Cool. Thank you so much for joining us today.
Thank you.
We like to leave you on a good note. Today's Tell Me Something Good is puzzles. One thing my family does on vacation is my mom will always purchase a puzzle, and we'll just put it out on the table, and then every so often during the day when we're all together, we'll just work on it for a little bit. And then by the end of the week, we're scrambling to get it done because we have only been doing little pieces of it at a time. But by the end, it is like a major family accomplishment to get the puzzle done. But we do it every vacation. It's kind of a tradition. And so today's Tell Me Something Good is puzzles. Thank you for joining us today. And until next time, take care of yourself.